Hello, my name is Jeff Stauffer, Community Relations Director with Elville and Associates, and welcome to our webinar today, the 7th in the Elville webinar series, Wellness Series, titled After the Dementia Diagnosis, presented by Ms. Ellen Platt of the Option Group and Dr. Michelle Fritsch of Retirement Wellness Strategies. So how this will work today, if you're new to our webinars, if you are, welcome. We're glad you're here. And if you're a returning attendee, we're thankful as always for your support of our webinar series. So you as the attendee are in listen only mode. However, if you have questions or comments, and we really want to encourage attendee participation during this webinar, please note them in the questions panel or chat box on the right-hand portion of your screen. And we also will be unmuting all attendees so you can speak through your microphones at various times during the presentation to share your thoughts with Ellen and Michelle. This has worked very well during our recent client care program presentation that we offered in March, as well as the wellness series presentation that Ellen and Michelle offered in March as well. So don't be shy in sharing your thoughts at any time. I know that we'll be very happy to hear from you. So also you received the presentation by email from me yesterday to take notes on if you wish. If for some reason you didn't receive the presentation yesterday, it's currently in the section marked handouts on your panel to download at this time. Everyone will also receive a post-webinar feedback email right after the presentation, and we do ask that you please take just a couple minutes to fill out the survey to offer us your thoughts about the presentation. Elville and Associates, we work every day with clients with the ideals of client education, collaboration, and compassion in mind. And we're always available for consultations to discuss your family's planning needs and look forward to being a resource to you in any way now and in the future. So at this time, since we have a lot to cover today, it's a jam-packed presentation, I'd like to welcome back and turn the webinar over to our presenters. Again, Ms. Ellen Platt and Dr. Michelle Fritsch who will share a bit about themselves and get the presentation started. So Ellen and Michelle, it is all yours.
Thank you, Jeff. Appreciate that. I'm Ellen Platt, founder of the Option Group, and we provide case management and advocacy services. So we are working with families all the time or help them navigate longevity, figure out what it is that they need to keep them safe and independent, functioning as well as they can. And many times we do work with families that are struggling with the journey of dementia. So we're going to be talking about that quite a bit today. Michelle?
Hi all, I'm Michelle Fritsch, and I left a career in academia because I saw so many people with preventable declines after retirement. So I help people come up with a clear strategic plan for preventing that decline after retirement and finding a way to prepare for health in the future. And Ellen and I have together over COVID created Propel Comprehensive Wellness. You probably received some information from us this week. If you've got any comments about that, just hit reply to that email. We would love to hear your thoughts. And before we dive into dementia, I wanted to do a quick review that when someone feels like their memory is slipping, there are medications that could be causing that, and there are physiologic things that your doctor can check on that could be causing that. So all of those things can be cleared up and fixed. And what we're going to talk about today is after that happens and everything fixable is fixed, we still have dementia, then what do we do? So I'm so glad you're here.
So a lot of times you hear somebody has dementia or they have Alzheimer's or you hear vascular dementia, all these other terms. So to kind of simplify it, dementia is an umbrella term. So that encompasses many other kinds, and I believe there are over 200 different kinds of dementia, different etiology of how it started. But the most popular that you hear about more commonly is Alzheimer's. About 50 to 75% of all cases are Alzheimer's related. So Alzheimer's is a form of dementia. There also are vascular dementia, Lewy body, frontotemporal. So it really is about the etiology and about how it started. So I just wanted to clear that up because a lot of people kind of use dementia and Alzheimer's interchangeably and they wonder what the difference is. So there are some differences with how the dementia starts or the disease process. And we're going to get into that in a little bit. So there are questions about how do we find if somebody has dementia. Is there a test that you can do, just like a blood test? There really is no test to determine if somebody has dementia. But there are many things, like Michelle alluded to, some physiological issues, some health-related issues, medication issues, vitamin deficiencies, and things like that, that's where we start. We rule out dementia by seeing if these are the culprits of causing it and reverse those underlying causes, and we can find out that it actually was not dementia, it was a medical issue.
It's always a relief when we're able to do that.
So as we mentioned, dementia is used to describe a set of symptoms, and Alzheimer's is a type of disease that is the most common cause of dementia.
And this might be a good place to talk about, we've been hearing in the news about amyloid plaques, and what does that mean? And it's just part of what we've learned so far about how Alzheimer's works. And it's now the focus of some medications that are being designed to try to do something about Alzheimer's. So we'll get to that in a minute. But it's part of that etiology of that cause of specifically the Alzheimer's kind of dementia.
And some of the things that we look into is doing a thorough medical review, family health history, looking at the medications, cognitive screenings or in-depth cognitive assessments that's done by a neuropsychologist, neurocognitive person. There might be some blood work, there might be some imaging, brain imaging that they would do, and just finding out how the characteristics of our thinking, what are we doing, what are we saying, what are we thinking, and where do the problems arise? Where are the gaps in our ability to function in the way that we used to? So with early signs of dementia, you might see some memory problems, particularly remembering recent events. Sometimes people say, no, I don't have it because I can remember 1942, every detail of my, parents', celebration, whatever it is. But really, the short-term memory is affected first. So the most recent events are what we start forgetting first. Might see some increased confusion or tasks that were really familiar to you. You have to start thinking about, wondering, like, I know I used this coffee pot yesterday. Why am I not understanding how the buttons work today? Or getting lost on the way home from the grocery store, which is something that you've done many, many times before. So it's a little bit of fogginess, maybe some reduced concentration. Might start seeing some personality changes or behavior changes. Sometimes depression will creep in because people may realize that there's something going on that they're struggling with and that things are changing. And it can be quite scary. So it's making sure that we get evaluated, see if there are any reversible changes that we can make, but also knowing that information ahead of time empowers us to make really good decisions going forward, even if we end up with that diagnosis of dementia. Some people will start experiencing changes in cognition. It could be as many as 10 years prior to the actual diagnosis. So there could be some things kind of happening, and we want to be proactive in our approach so that we can slow the decline or come up with strategies to kind of bridge the gaps that may start to happen in our cognition.
Right, Ellen and I were kind of talking before we got started today of some important things we wanted to squeeze into this presentation. And a few of those are, sometimes when we start to see signs, if nothing else, even if it's something that goes away, it can be a good trigger to make sure that we've had really important conversations and made big decisions while we're able to do so. And so if you know someone, if you experience this, you think maybe your memory is slipping, it's a great time to think about, have I made it clear what I want in the future in case this does turn out to be a diagnosis, a long-term diagnosis like Alzheimer's disease? Make big decisions up front. If I'm no longer safe driving, how do I want you to tell me that? What strategy can we come up with to deal with that while I'm still able to be part of the decision making? Same with money, same with belongings, same with properties, same with everything about your estate. And then as we go along, maybe Ellen, we can make sure we talk about things about safety and locks a little bit later. But I'm just looking at my little list here.
Yeah, and this is a great time to review your planning documents to make sure that it still reflects what you want. And if you're thinking ahead, knowing that a diagnosis of dementia is progressive, we want to be proactive and make sure that the plan that we're thinking about going forward is going to reflect those changes. So sitting down with Jeff's firm to be able to review your documents, make sure, do you have a power of attorney? That is somebody that you trust to make decisions for you in the event you're no longer able to make them. And that could be for healthcare decisions, that could be for financial decisions. And it's really important to kind of get that lined up, make sure that everything is up to date and accurate. Who is the beneficiary? Who do you want to be able to be your voice in the event that you end up in the hospital and difficult decisions have to be made? We want to make sure that we have shared what our wishes are. What kind of treatment do we want if we end up in the hospital? What kind of treatment do we not want? Do we not want artificial hydration and nutrition? Do we not want to be resuscitated? What is it that we want? So there's no right or wrong answer. It really is understanding what's important for you and having a conversation with your primary care physician to understand what your thoughts may be and where you might stand as you're preparing these planning documents.
Good point. Here we go.
Yep. So Alzheimer's is the most common form of dementia. As we said, 50 to 75% of the cases of dementia are Alzheimer's. You may have heard of early onset Alzheimer's. That's different than early stages of dementia. Early onset is somebody who actually starts showing signs in their 40s or 50s. There have been some even as early as their 20s and 30s. And those typically tend to be a very fast progressing disease, and they unfortunately pass much earlier than somebody who has a diagnosis of dementia older. Many times you'll see depression, people start forgetting names and recent events. And I know everybody says, oh my gosh, I just walked in the room and I forgot why I came in here. Or I put down my keys and I can't remember where they are. But if you're able to go back and retrace your steps, it probably isn't dementia. If you're able to recreate it and figure it out, it's probably not a cognitive issue. It may be more of a focus or attention thing, paying attention to where I put my keys, or not hanging them where I always have them. So that's kind of how you can distinguish. Some people start hitting the panic button when they forget something, and it doesn't always mean it's a diagnosis of dementia. But you might start experiencing confusion, mood changes, word finding difficulties, may just start forgetting things that were really common that you did before, and you're wondering what's going on.
Mm-hmm. I included vascular dementia just as a comparison, and it's the second most common kind of dementia. And I will tell you, one of the differences is Alzheimer's, whether it's a fast progression or a slow progression, it tends to be a fairly even type of progression, versus vascular dementia happens with each new vascular event, each new blood clot in the brain, each new little stroke. And so someone will decline, and then it'll plateau. It'll stay the same until the next event. And then there's more decline, and then a plateau. So I just wanted to toss that in there, Ellen. Anything else you wanted to say about vascular?
No, and strokes, TIAs, transient ischemic attacks, which are little mini strokes, head injuries, traumatic brain injuries, can all be culprits.
Good point.
So these are a number of other causes of dementia. You may have a co-occurring disease, and as part of that progression of that disease, like Parkinson's or Huntington's, Wernicke-Korsakoff's, and CTE, which is the concussive trauma, you'll see it's a degenerative progressive disease, and many times as it progresses or gets into the later stages, you'll start seeing a lot of cognitive decline and the actual diagnosis of dementia.
So what if it is Alzheimer's? We wanted to take some time today to walk you through, if you ever hear that word, if you've already heard that diagnosis and you're experiencing it, we really want to bring you hope today that there are a number of things that can be done, and we never want you to feel that you're walking this journey alone. So if nothing else, I think those would be our top 2 goals for today. And we would love to hear your feedback. Are there any questions before we move forward? All right. I can't see the chat. Is there anything in the chat? Helen, are you still there?
I was trying to
Okay.
look at the last screenshot where you had the causes of,
Yes.
yes. Thank you. Thank you so much.
You're welcome. You just wanted to look at it?
Yes, I'm done. I took a
Okay.
picture of it.
Oh, there you go. Very good.
So yes, the microphones are open. If anybody has any thoughts they'd like to share with Ellen or Michelle, or has any questions they'd like to pose, please feel free to use that way to communicate, or if you'd like to put them in the questions panel or chat, please do that as well.
You know we love for this to be interactive.
Looks like we have one other question in the chat, in the questions panel. It says, it may be extremely important to mention that if there is concern about the potential for dementia, if long-term care coverage has not yet been secured, don't wait, get the insurance before a formal diagnosis.
Certainly an important option to consider. And you can imagine with the baby boomers, with a large generation reaching ages 65 plus at a fast rate, just because of where Alzheimer's is typically identified in our lifespan. This is going to be a condition that's going to impact, as far as total numbers of people, a rapidly rising number of people. And as you know, it impacts not just the person with the diagnosis, but everybody around them. So if you're not currently impacted by Alzheimer's in some way, it's probably likely to change in the next few years. Someone was saying something.
So maybe while we wait for that person maybe to chime back in, do have a couple other questions. So this is a good question. How do you approach a loved one when they don't cooperate with cognitive tests doctors give them?
Do that quite often. It is difficult. It's, you know, somebody's struggling to maintain their independence, and having that formal diagnosis or that piece of paper that kind of shows us in black and white that there is an issue can be quite scary. So what we need to do is just be very reassuring. I do cognitive screenings as part of my job all the time, and I often describe it as being a planning tool. It's going to help us understand where you are. It's going to be something that we can compare to in 6 months or a year to see how quickly it's progressing. But it empowers us to make important decisions. It's not something we have to tell anybody about. Sometimes I will recommend that they share it with the primary care, because then the primary care physician actually has some objective information as well. But really, it's for our information as working together on your healthcare team is to figure out how is this information going to be useful. So it's really an empowering planning tool.
Thank you. And another question, what actually causes death during Alzheimer's and dementia cases?
That is a great question, and it's a
the
number of different answers. I'm sorry, go ahead.
Yeah, and he just goes on to say, is it a situation where the heart just stops beating, or is it something else completely separate from that? Can you expand on that, please?
So with Alzheimer's disease, there are a lot of other things that happen. So one, in general, people tend to start to lose weight. Their immune system tends to not be quite as robust as it used to be. It's hard to, as it progresses, to make good decisions about, I'm going to eat more fruits and vegetables today, and I'm going to go out and exercise. And so without all of those aspects of living a full, cognitively engaged life and doing all of those healthy habits that we do during the day, over time, things start to change. So for some people, it's an infection at the end that they've been more likely to get because of the Alzheimer's disease weakening their overall weakened immune system. Sometimes it's because they've not remembered to take their medicines, or something's happened and other conditions that were controlled are no longer controlled. Sometimes as the weight declines and the person is not as functional and moving, then they can get wounds, there can be a tragic fall. And so it's oftentimes more the Alzheimer's played a role that necessarily was directly the cause of death, is what I've seen. How about you, Ellen?
Yeah, I agree. A lot of times it is, co-occurring with some of the other progressive diseases that we've talked about, or perhaps it was another stroke that kind of was the end of it. I have seen people who are very progressed with dementia, and what ultimately happens is they start having trouble swallowing. So to have a clear pipe, often it is that infection, or they aspirate, which means they're breathing in maybe food or something that gets lodged, and then often leads to pneumonia, and it's very hard to clear that up. It may be that, or it may be ultimately the various systems and organs of the body start shutting down.
And again, these statistics that you see here, a lot of that has to do with just the advancing age of our population, not just in the US, but worldwide. And so with the advancing age of the population, or a large number of people who are reaching the age where Alzheimer's is more likely to happen, then we're going to see these numbers continue to climb. Not necessarily that individuals are at greater risk, but more that more people are reaching that stage of life and then living much longer. And so the more we have people over the ages of 80, 90, 100, 110, then this disease state tends to be more and more prevalent as we do get older.
So as you can imagine, Alzheimer's is the most expensive disease. It's estimated that it was about $250 billion in 2017 to provide care. And that's not really taking into account the families who stop working and they're no longer earning. There are a lot of other costs that are associated to Alzheimer's that aren't even captured in these numbers. But about $1 out of every $5 spent by Medicare is on Alzheimer's care. And about every $100 spent on finding a cure, about $16,000 is spent on care. So as you can imagine, it's a very expensive proposition. And it's only growing because of the baby boomers who we're just having an explosion in the number of people who are at the age and maybe experiencing dementia.
The good news of this is it's spurring a lot more research. There is a lot of emphasis on we've got to figure out what's causing this, how to identify it early, maybe even while someone's still at the high risk stage, and then figure out what to do about it.
So the onset of symptoms are gradual and progressive. And like I said before, that you could experience early symptoms for 10 years before you actually get a diagnosis. So it often is very slow. If something dramatically changes or just gets so much worse all of a sudden, we need to go back to those medical issues that we talked about before, or look at the medication, or look at vitamin deficiencies and see, you know, it could be something as simple as a urinary tract infection that magnify temporarily the symptoms of depression or dementia. So we want to make sure that what we're experiencing is in fact a progression of the disease, and having a good collaborative relationship with your physician is a great place to start.
Can I pose a couple other questions,
Yes.
Ellen and Michelle? How can you differentiate between the cognitive decline from NPE from Alzheimer's?
From MTE?
It's N like Nancy, P like Paul, E like Edward, NPE.
I need
I
to
can
know what
ask-
that is.
I can ask the gentleman to expand on that if you'd like, so I
Yeah.
can get back to that one, and we can move on to the next one here for a moment. Can you please give me more information on Lewy body dementia? My 76-year-old sister was recently diagnosed with it.
We saw that Lewy body's not as frequent as Alzheimer's, and not as clearly defined, like what are the right steps to take to treat it, other than a lot of the general things and the safety parameters and such that we're going to talk about certainly apply to all of it. Other than that, anything to add, Ellen, about differentiating care for Lewy body?
We often see that the progression of that disease includes lack of inhibition and impulsiveness. So a lot of times we need to keep that in mind, especially as we're talking about safety and, you know, using good judgment decision making. Sometimes that becomes very difficult for somebody with Lewy body, and we see the same for frontotemporal dementia.
And that's because it's all impacting more that very front part of the brain. That might make this a good time to mention something to start thinking about when a diagnosis is made, or even when you're anticipating a diagnosis, is safety parameters. And one of those is, I know in families that I've worked with over time, we tend over time, people don't sleep as well when they have dementia. Nights and days get kind of mixed up. And so there can be some wandering around at night, and people can wander out of the house. And if, you know, the families or caregivers can be exhausted and not even realize it. So one of the early safety parameters I always recommend is some sort of mechanism that protects the doors at night, the doors that leave the building, leave the house, in a way that the person can't easily get out of them. So sometimes that's changing the type of lock to one that they're not as familiar with. Sometimes that's an extra kind of latch or a bolt, or even having one of the alarm systems that if somebody walked out the door while the alarm is set, that you'll wake up and you'll know it. So that is a safety perimeter I encourage early when someone is starting to deal with this, so that we don't wait until someone's wandered off and been lost, and then we're trying to figure out what to do. Another one related to that is to let your local authorities know as soon as possible, so that they have a picture, they have a description, and they have some guidance on how to best approach that person. In case they do wander off, authorities can be alerted, immediately start looking for them, but know their name, know how they like to be approached, be nice and calm, which is, I guess, things that we're about to get into. But just two early things I have people work on is just in case somebody would wander off, working on the locks and letting authorities know.
Kind of along those lines, there are also personal emergency response systems, or a bracelet, necklace, things that people can wear that actually has a component in it that has a GPS. So if somebody does wander off, you can find them fairly quickly. There's also ways to do that with a cell phone. So if they are still using a cell phone, that's a way that you can help find them in the event that they wander away.
That's how my kids find me now. So we're already practicing.
So when we're looking at behaviors, everybody has a different journey. So you're not going to see all of these behaviors with every person, and you may see some early stages and some later, or it may be hit or miss. You'll see them sometimes, but not all the time. So you may find somebody emotionally labile, which means highs and lows or quick or dramatic shifts emotionally, or their mood changes quickly. You may see sundowning, where there's increased agitation later hours of the day, where they're restless or they're pacing, maybe a little bit more upset, maybe talking about wanting to go home, and they're home. So a lot of times when they want to go home, they're really thinking about maybe their childhood home, perhaps, that they may have stronger memories at this point. Anything on there that you see, Michelle?
All of it. I'm working with a family right now who they're really having difficulty with nights and dreams that appear real. And so the person with the Alzheimer's is waking up frightened, and it's just very difficult to calm them because in their mind, what they just dreamed really just happened. And so just being aware that there are a lot of behavioral changes that can occur, and there's no predicting which ones for which people. So again, the more you can kind of plan ahead, make sure you know this person while they're still cognitively intact, being able to have good conversations about sort of their preferences and start developing mechanisms that you're going to use later that are going to be according to the way they like to talk about things, or maybe even scents, favorite flowers, favorite things that can be calming mechanisms later in the progression. I put the little corner in the box in the corner on this one, that the two things that often lead to someone no longer being able to manage things on their own, so that a family member gets involved or they move to some sort of assisted living, are either they can no longer manage their medicines or their finances, but there are a lot of other things. So Ellen, kind of walk us through some of the typical changes.
We'll start, we'll see up on the top left where you see subtle changes in personality, and somebody may be the mood or the affect may be a little bit different, or they may be a little flatter, like more not as animated. They may be a little bit flatter. You start seeing those subtle changes, and they might kind of look normal, but you realize that there's some loss of recent memory. It just continues on. You'll find word finding difficulties, getting lost, doing things like that, and you'll see increasing difficulty with it, able to focus or pay attention to things, having more difficulty understanding or following the thread of a story, or finding words or understanding idioms or sayings that are pretty common, kind of not understanding what people are saying. They might start bouncing checks or forgetting that bills need to be paid. Or you start seeing collections notices. You might start seeing food in the refrigerator is getting rotten or expired, and just not eating like they used to be eating. And like I said, getting lost driving around. So you start seeing these little changes. Maybe one by itself is not that concerning, but when you start seeing progression or seeing several things at the same time, that's when we need to start worrying about safety and decision making, and want to start putting that care plan in place to support them underneath. So in case there is an issue, we have a plan B. We see people start getting more rigid, more difficult for them to change activities quickly, or a move would be very upsetting. So we just kind of look at all these different things, and usually it's because of the dementia and its progression that makes it more difficult.
Good point. Aligned with that inability to adapt to change, one of the things I often see is the person no longer wants to go to places they used to go, like family gatherings, places of worship, community events, because one, they realize they're having a harder time with names and words, and it's upsetting to be out of their environment in a different place where things are kind of moving quickly and there's just a lot going on around them. So more and more no thank yous to invitations to go places.
Yeah, and as it progresses to middle stage, then that is really when we start seeing withdrawing from social interactions, social situations, so that we start becoming isolated. And then we don't have the engagement, and we're not using our brain in ways that we used to with interacting or going places or having dinner or having conversations. And then it's kind of, you can see a downward spiral where they start isolating themselves. And we saw this quite a bit during the pandemic, where people who had early stages of cognitive decline, but then with the lockdown, they were completely isolated, and they really lost that engagement and that interaction, that social component that helps maintain cognition.
You know, it was just such a horrible period, because it appeared that numerous people progressed rapidly in their dementia process. And I think we learned a lot about that process in a devastating sort of way. But it's been pretty horrible to see what families have gone through, and when they've been able to reconnect with their loved one after being separated. A lot of negative impacts.
Yeah. And at this level, we also start seeing changes in speech, maybe difficulty, a lot of difficulty finding words. We might start stringing together sentences that aren't making sense. They may be nonsensical, and we're just substituting something to finish the sentence, and to the person hearing the sentence, it's not making sense. So sometimes we have to probe or ask. We don't want to rush them. We want to give them time and space to come up with their sentence, but sometimes we may need to help them with a word if we know what they're trying to come up with. This is also where people who have English as a second language may start reverting to their original language of origin. And that makes it more difficult to communicate that way too, if they're speaking a different language. And this is also where we start seeing behavioral problems, where somebody gets so frustrated because they're not communicating, and in their mind they know what they're thinking, but this person standing in front of me is not understanding what I'm trying to say. So might start seeing behavioral outbursts or tears, or the depression may be getting worse. So these are things that we want to look out for, maybe some of the red flags to know that things are progressing to the next stage.
And this is one of the many reasons that this is such a cruel condition, that you know early on that you're not communicating the way you used to, that something is different in your brain, that especially once you hear the diagnosis, you kind of know the path that is ahead. So it is very common for there to be depression alongside the cognitive impairment, and those can look very similar. So it's up to the family and the healthcare team to really know that person, to know, is this a situation where we need to focus more on the depression, or is it a sign of the advance of the dementia? It's difficult to tease that apart, so great communication is an important sign through, or an important aspect of working through the signs of change at this point of this condition. Before we go to late stage, are there any other questions or the clarification on the NPE?
Thanks very much, Michelle. You were reading my mind. There are a couple other questions here. Going back to the previous question, the gentleman originally misspoke, which is fine. So the question should have been, how can you differentiate between cognitive decline from normal pressure hydrocephalus from Alzheimer's?
I don't have a clear answer to that, other than through, neurologic assessment to determine if hydrocephalus is part of the picture and could be causing the symptoms. Do you have anything to add, Ellen?
No, it really would be a specialist who would be dealing with the MPH, is what it's normal pressure hydrocephalus. Really, it's pressure, water pressure on the brain, and it impacts your ability to think and function. So you may see similar symptoms to some of the others, but it really is led by that specialist who's treating you for the condition.
And there's
Okay.
usually a shunt or something to allow some drainage, depending on the situation. And so symptoms can appear to get better when you can relieve the pressure. And then as the pressure builds back up, symptoms come back.
Okay, very good. Thank you.
Person
A
specific.
couple other questions here. Does diabetes type 2, age 43 years old, cause or enhance dementia?
That is a great question. And I mentioned earlier, with the large increase in the number of people that have dementia and what's anticipated to continue to grow, there's more and more research, and some of that research is focused on what are associated conditions, what are lifestyle choices we make, and how do they increase or decrease the risk. And so I think we're going to see much more clarity around that probably very soon, because I know a lot of researchers are really trying to focus on that and figure that out. So it's a great question.
Okay, and last question, a couple parter here. Recent article mentioned that blood tests may indicate presence of amyloid plaques in the brain. What tests are these, and are they expensive? And any opinion on their reliability of these tests?
To my knowledge, those tests aren't available commercially yet, and they're still being studied. There's also tests for genetic factors, and they're still trying to figure out exactly what genetic markers are most accurately associated with Alzheimer's. So if you've ever had one of those 23andMe or one of those big genetic tests, you know that there's a couple of markers that they look at. And that can really freak people out, to be frank, because if you are positive for that marker, it does not mean that you will have Alzheimer's. It means that you've got an increased risk or a sort of a predilection toward that direction. But those other factors, whether it's our lifestyle choices, our environment, there are other factors that either turn that on or off. So some people will have those markers and live their entire life to age 120 maybe and never have Alzheimer's. And others will have that marker and find that Alzheimer's is in their future. So we're at a point where practical application and scientific findings are sort of leapfrogging on each other. And sometimes it's scary because we get news that we don't know what to do about it yet. So I'm making this answer way too long, other than to say there's a lot that's being studied right now, and I think we'll know more moving forward. But I'm not familiar with a test that you can actually go access without being in a study right now that determines your plaques. Have you seen anything different, Ellen?
No, that's pretty much what I've seen. I know there's a lot in the works, and we've been supporting the Alzheimer's Association and hear about a lot of the breakthroughs that we're making, not only in the markers, but also in the medications. And I think we're really coming close. Again, there's no cure, but right now there are some ways that we can slow the decline. But I am confident we're going to get a cure eventually.
I think we'll figure out what's causing it, and then that will allow us to get in front of it. Agreed.
Okay, thank you. Those are all the questions for now.
So when we get to the late stage of dementia, that is when people may or may not recognize family, or they may not recognize themselves in a mirror. Often you'll be able to see when they're talking about, waiting for somebody to come pick them up. They may be, you can kind of get cues about where they are in the timeline of their life. They may be talking about something when they were 20 years old. So you kind of have to go along with it. That a lot of people think, well, my mother died and how do I tell dad? And people will grieve again and again and again if they don't have the capacity to retain from one day to the next that a family member died. It's important for closure. Family sometimes wants to make sure that they know, but to have this person grieve on a daily basis when they wake up and they're looking for their spouse and the spouse is not there, there are ways not to handle that, and not saying, don't you remember she died last year? Don't you remember? It really is at this point, how important is it? What kind of harm does it do to force that piece of information on them? So we want to make sure that they're supported, that they feel validated. We may need to distract from that conversation to say, well, let's go get something to eat. We may need to communicate by body language and not through verbal language. We may need to use a lot of touch or hold their hand and bring them where you want to go. You may need to use sensory, use their senses to be able to communicate or help them relax. That might be smells like lotions or lavender, which is a stress reliever. So a hand massage with a lavender lotion is a great way to just spend time with somebody who's maybe no longer verbal. Touch is amazingly healing. Music, playlists from songs that they used to enjoy when they were younger is a great way. And there have been lots of studies how people have kind of come alive again by hearing that old music. It really kind of connects with them internally. Looking at nature, looking at books, pointing out things and kind of just narrating what you're seeing and letting them enjoy things like that. So that's a great way to spend time with somebody who may be forgetting or not communicative. I spent some time with a client who loves looking at her yearbook. And we will go through and you can see where she's written over the years where this person went to college, who this person married. So she tried over her lifetime keeping track of friends from high school. But when she looks at that book, she can start talking again about clubs that she was in and things that she had enjoyed. And it's really kind of neat. So something that's very familiar to them that helps them reconnect to their past, reminiscing. I've had clients who are worried or upset that their loved one isn't here, and really distracting by acknowledging what did you like about them or what was fun about them, and letting them reminisce and think about that person in a positive way of how they remember them is a great way to let them spend time and be able to enjoy the thoughts of a loved one even though they may not be here.
Those are all absolutely fantastic points. And I thought of a few more. When it's your family member or someone close to you, it's hard for the family, it's hard for the people around them to go from relying on that person to be the person they've always been to accepting who they are now. And so I see far too often what feels like berating and belittling, like, you know how to do that. Why aren't you doing that? Get out here. Let's do this. And this is a time when that person is changing. They're not able to respond in the way that they did before. And so encourage families and those around them to start making changes that keep things more structured, less variability, because more structured can be easier to navigate day to day, and calmer, maybe softer lighting, things that just kind of keep things in a more calm sort of place. Maybe it's no longer a treat to go out to dinner because that is too disorienting. If you want to have a special meal, bring that in so that they're still within their calmer type of environment. Another thing that you made me think of, Ellen, is sometimes when you're the person with that person with the cognitive decline every day, you don't see the changes as clearly as when somebody who doesn't live there comes in and maybe hasn't seen them in a week or a month or 6 months. And then they can really describe to you as the caregiver just how much change has really evolved. Because again, when you're in it every day, it's not as obvious. There was one other thing. Oh, and then often if there's a family member a generation or two down from the person who has the cognitive impairment, who looks like someone. So for instance, my grandmother thought my son was her husband because she was cognitively back to probably her early 20s, and my son was in his late teens. And so he looked like my grandfather did when they first met. And that's where she was cognitively. So she recognized him as her boyfriend. And that was hard for both of them to process, but it made sense because when you looked at pictures of my grandfather at that age, my son did look a lot like him. And Ellen, do you want to talk about some of the day programs and what they're doing to sort of fit the comfortable era that people with dementia might be in?
Yeah, there are some adult day programs where people can go during the day to have engagement and activities. And there's a recent one called Town Square that is opening, and it looks like a 1950s town when you walk in. It's all indoors, but it looks like a park. There's a 1955 Oldsmobile, and around the perimeter of the park is this 1950s village. So there's Rosie's Diner, there's the gym or the billiard room, there's the old-timey movie theater, and it looks like this town, and people can go there during the day and have engagement, reminiscent of the 1950s, because folks who were looking for that type of care were growing up maybe in the 1950s, and that's where their memories are most intact. So they have old Life magazines, and they have things of that era, signs, commercials, things that you might have seen walking down the street during that time. And it allows people, they call it reminiscence therapy. It allows people to reminisce of a time that was very familiar and very happy for them. And it gives them that chance to just engage in a way that they can't on Main Street today.
Does that bring up any questions or comments or ideas from anybody? And Jeff, we're only about halfway through. There's so much to talk about here. Could we turn this into a part two? Would that be okay?
I think we certainly could, Michelle. So as a reminder, the microphone is still open if anybody has any thoughts they'd like to share verbally. Do have a couple of questions in our questions panel regarding weight loss. Is weight loss determined by a percentage of actual weight or by just a number, say 20 pounds?
I don't know that it necessarily needs to be either, but just a noticeable change that somebody's not dieting. They're not, they're not trying to create a change. And the two biggest reasons that I see it are either they're forgetting to eat. So maybe there's not yet somebody involved in their care throughout the day, and they're still relied upon to remember to fix or eat their own meals, and they just completely forget. Or next time, I guess, we'll get into the medications, and that can have a big impact on weight loss as well.
Something else I'd like to mention about weight loss is that with dementia, some people may no longer be able to have that connection for hunger and needing to eat. So they don't have the need, or they don't understand the need, just like they may not have the ability to connect their need to go to the bathroom. It's just not connecting in the brain. So then they may become incontinent and have more accidents because they're not making the connection to I'm hungry, or they're not making the connection to the biological connection or the physiological. They're not noticing the signs. So they may not remember to eat because they're just not hungry. And then again, we have the swallowing difficulties. And in terms of a number, it really is if they're losing weight over time, and that becomes a factor when we start considering hospice for somebody. And that is one of the factors that physicians use, or that hospice uses to keep somebody on hospice, is that there's continual weight loss.
You know what, Ellen, you bring up a really good point too that we haven't really talked about, is the more steps involved in doing something, the more difficult it becomes as cognition declines. And so something like preparing a meal, even if somebody already cooked it and put it in the refrigerator and all they need to do is pull it out and microwave it, that can be too many steps, because you have to remember where it is, retrieve it from the refrigerator, appropriately prepare it for the microwave, put it in the microwave, remember what buttons to push, pull it out of the microwave without burning yourself, then eat it. And although we do that every day without even thinking about it, it can become difficult. Same with going to the bathroom. Think about how many steps are involved with, oh, I need to go to the bathroom. I know where the bathroom is and how to get there. Once I'm in the bathroom, I know how to rearrange my clothing. Often with all of those steps, someone can have an accident before they get there, because it's just too many steps to remember to do that on your own anymore.
Yeah. So as caregivers, one of the things that we do is break down things into simple steps, maybe one-step directions, one thing at a time. We have, for some of our clients, created a list, or kind of the steps written out, posted next to the microwave, or the steps to brush your teeth posted on the mirror in the bathroom. Get the toothbrush, get the toothpaste, scrub up and down, hit all of the teeth. Whatever it is, we can break down into one step at a time that some people can follow and still be a little bit more independent for a longer period of time.
So Michelle, as a kind of a precursor to, I guess, what will be part two, since you're looking at the presentation, I know we are just about halfway through. One question we have here is wondering about if there are new medications. We have a good client of ours here that says, my mother had Alzheimer's 20 years ago, and I only had remembered Aricept as the main medicine, and have there been new medicines? Can you allude to anything that you'll be discussing next time, or any brief thoughts?
That is perfect timing, because our very next slide is medications. It's complicated. So I'm not going to go through too much of it right now, but that's where we can start next time. And there is a lot for us to talk about with Aricept and its cousins, like the medications in that category, as well as newer options that are both out and those that we believe are coming. That might be where the real hope is the ones that are coming, hopefully soon.
And I guess the last thing would be, I had a question. Are there any really helpful links that you would suggest for people that want to get more information about Alzheimer's and dementia, or questions about their, one person referenced their gut health, anything that you would suggest that I could send out to people in my follow-up message that I typically send to people?
Well, I could suggest as a starter the Alzheimer's Association, which is,
Sure.
The website is alz.org, and that is a great place for information. They've got lots of resources, they've got lots of videos, they have pamphlets. information on local branches of the Alzheimer's Association, and they have a 24/7 helpline, which is 800-272-3900. And you can call that 24 hours a day with any kind of question about Alzheimer's or needing any kind of information for support. They can help guide you. So that's a great place to start. They also have support groups, both virtually or in person. They have lots of options to help support people with dementia and their families.
Great. Yeah, I've been on
That
that
is such
site.
a
It is
welcome.
a great site. Thank you.
I didn't want to end on such a bad side, so I switched back to the first one.
And yes, a couple of questions. We always have this. This has been recorded, just like all of our webinars in our webinar series has been recorded, and it will be available on our YouTube channel. And I always send out the link in my post-webinar follow-up message. So please be sure to read that message, and the link will be in there for you. So I guess with that, we'll go ahead and end today. And the third Tuesday of May, which I can't believe we're going to be there soon, we will continue on with this very important and relevant discussion about after the dementia diagnosis. Michelle and Ellen, thank you for thinking of this topic. It's touches a nerve with so many people. It's such a prevalent disease, and hopefully we're continuing forward with moving towards some type of cure and more information about it on a daily basis. So, so you guys do a great job in educating and sharing knowledge about it, which is a great part of it. So thank you. So with that, we'll go ahead and end today. I'll go ahead and send out some follow-up information in my post-webinar follow-up email to everybody about today's presentation. We also had earlier today a webinar on Medicare basics. If you want to get information about that presentation, I'll include the video from that. It was a good presentation. And also I'll send some information out about our client event, which we have on May 21st. And we're going to be back in person for that client event. It's a beloved event we have here at Elville & Associates every year. And it's a lot of fun, a lot of great presentations, and live music, award-winning food, and we're very blessed to be back in person on May 21st at the 10 Oaks Ballroom. So I'll send a link to the invitation and hope you can all join us. It'll be a lot of fun. You don't have to be a client. All are welcome, so hope you can attend. So with that, we'll go ahead and end today. Appreciate you being part of the Elville webinar series, and we look forward to seeing you again soon. Have a great day, everybody.
Thank you.